on clinical effectiveness and the modeling. And this will kind of bring us to specific votes on, again, on clinical effectiveness, on potential other benefits and contextual considerations, and on long-term value for money. So I will try to watch the clock, but we should have enough time to return to some of the important issues that you started to deliberate upon this morning. So I need all the CEPAC members to go ahead and make sure that you're in the voting software, and please let Maggie on the staff know if you're having difficulty in any way with that. We should have 15 votes otherwise. And just to tee up the conversation, let's go ahead and show the first voting question. Okay, so first I'll read out the patient population in the question. So the population are patients with triple, quad, or pentarefractory multiple myeloma who have tried at least 4 prior lines of treatment. And this patient population is consistent with the FDA label for our first kind of drug here, which is belantamab. The question is, given the currently available evidence, is the evidence adequate to demonstrate that the net health benefit of belantamab is superior to that provided by usual care? Again, for patients in that patient population. All right, so with each of these questions, I'm going to start just by asking the relevant member of the ICER research team to very briefly remind the CEPAC of the rationale behind our evidence rating, and to point to the tables in the evidence summary that they think are most germane, and then we'll open it up to further questions and discussion. So, Say, can you do that for us, please?
Yeah, just to summarize, our conclusion for this evidence rating was promising but inconclusive, and the evidence would be in where is that? I'm not quite finding it, but it's basically what we showed is that for some of the outcomes, such as overall survival, belantamab did seem to have improved outcomes compared to usual care, but for other outcomes, such as overall response rate, the results were much more equivocal. And so because of that, we gave it this promising but inconclusive conclusion.
Okay. And the tables in the evidence summary, they do kind of span from generally table 2, which is an overview of the key trials, through table 4. So 2, 3, 4 are really the key tables where the data from the trials are located. And while you're thinking about any further questions, I wanted to go ahead and just ask one of the clinical experts, if they don't mind, and it can be either one certainly. But this issue came up during the discussion of the relative weight that people should put in their minds between the progression-free survival findings and the overall survival findings. We heard different perspectives on that. Would the clinical experts like to weigh in on how you think you and others are thinking about that for Blenrep? Whether you think there's again, the question about whether it seems like the progression-free survival is not large enough to account for the size of the overall survival improvement.
So let me ask one question, Steve, before I answer that.
Sure.
The GSK representative did make a comment that the ratio of PFS to OS, using a different reference that she cited, was quite wide, and it overlapped this number that we are getting right now for DREAM2. What is the response for that question? I know we didn't get the answer correctly there, but she said, based on our own reference, that the OS in the relapsed refractory population can be anywhere from 3 to 6, or sometimes whatever number she stated. But I just wanted to know why we didn't use that reference, or is that something that was considered and found inadequate for some other reason?
Sure. So would you like to weigh in on that?
So we were actually testing, and neither of us really were sure about the reference that she mentioned. So we have 2 meta-analyses, one from I think 2017 and one from 2019 or 2020, which showed that for the previously published myeloma studies, that the PFS to OS ratios was in a fairly tight band between about 2.5 to a little over 3, maybe 3.2, 3.1. And so the numbers that she's saying, without having seen the primary study, I can't really comment, but it's definitely something that we'll have to look at. But I'll take a look at it.
Sure. And my feeling is also it's about 2.5 to 3. So I was kind of surprised about that comment. So I was like struggling to see what particular paper that she was referring to. But, keep in mind that when you have a trial without a control group, and it's not a randomized trial, we know based on prior experience that if you have myeloma, you don't respond to a treatment that doesn't work. So the 30% response rate is real. The PFS estimates or the duration of response are fairly straightforward, and you can compare to benchmark. But overall survival is always very difficult to compare to benchmark because it depends on so many other factors, particularly what available therapies were around for this group compared to the Mammoth study. So the two possibilities are that belantamab has an effect that is far more on overall survival because it does its job, and even if there is evidence of disease progression, there is some amount of stabilization of the disease that allows patients to live longer, and so that the overall survival benefit is truly coming from the belantamab. The other option, of course, which I think is more likely, is that you cannot compare non-randomized data, and the best adjustments you can do response rate, PFS, duration of response. But overall survival is always the trickiest to compare to because there is a reason why the Mammoth study patients did not receive trial treatment. And the trial patients are a different category, that they are able to go get the trial, so they may have access to other trials and other treatments that affects the overall survival.
Dr. Rajkumar, just a quick comment. I do believe she was referring to the Felix study, but specific trials within that paper. And just so the panel understands, this is a difference in the mean, or obviously we're reporting the median, but difference in the meta-analysis versus some sort of variation around that. And the paper by Felix clearly says that there's no evidence that differs by type of surrogate or any other factors. Furthermore, we actually relied not only on the Felix paper, but there's another one that is a conference proceeding that adds about 8,000 multiple myeloma patients to the existing 23,000 from that study that found a 1-to-3 ratio. So just wanted to mention that.
And just to throw in a bit more about the Felix study. So the overall estimate was a median of 2.5 months of overall survival for every month of progression-free survival, event-free survival, or time to progression. So that all the surrogates were combined together, but the 95% confidence interval was about 1.8 to 3. So all within a relatively tight range.
All right. Open to the CEPAC. This is on belantamab. Now I'm going back and forth between the trade name and the generic name, sorry. But any questions about the evidence? I will ask one more question just to prime you. And this may go right back to Vincent again, or to Anita. People are going to be weighing the benefits with the visual side effects to some extent, if they're thinking about a net benefit in addition to the uncertainty. From a clinical expert perspective, is what we saw in the trials as far as the visual effects, is that likely to be what we see in the real world? Is it likely to be potentially more, potentially less? Will doctors modulate the dosing to try to avoid that toxicity? How would you advise the CEPAC to consider and weigh the harms that we're seeing from the clinical trials as they might play out in the real world?
So I've had my own patients on belantamab, and I will tell that, when you read the paper about the 40% grade 3 to 4, it does sound quite bad for keratopathy. But now we are making sure that the patients are getting their eye exams. And I think probably in DREAM 2, the every 3-week cycle was probably what contributed to this. And when you get 2 cycles, you are getting the 40% rate. But for most patients outside of a trial, you don't have to take them off the trial, even if they are not getting treatment for a month or 2, and you can go back to the treatment once the keratopathy resolves. So in real world, I think the keratopathy will be less of an issue.
Yeah, and patients also are now counseled to use eye drops throughout the course of the day, and that seems to mitigate some of the symptoms. And in my personal experience as well, while on paper it seems like a very big ordeal, and I certainly I do acknowledge that having to see yet another specialist in the midst of these treatments does add to burden. It seems to be going more smoothly than what I had initially thought it would.
Okay. Now, again, when this issue about the comment about Blenrep came up in the OS PFS, GSK was offered the opportunity to submit a written comment that I'm just going to read out because we want to try to keep it fair for all the different folks. But let me just read this, and then again, we can have further response from the ICER team if needed. If you look, this is from GSK, if you look at the underlying data for Felix 2013, the trials were not conducted in triple-class refractory patients, nor heavily pretreated patients. Despite that, if you consider only the phase 3 trials, looking at the individual publications, you would find that the ratio of PFS to OS is between 3 to 7. Furthermore, the authors themselves state that these results suggest that our model is less suitable for predicting median OS in relapsed refractory multiple myeloma. Therefore, the ratio mentioned in the evidence report is not applicable to this population. Not sure if that's more of a comment about the modeling as opposed to the clinical effectiveness considerations, but it obviously affects both. Dan or Brett, any comment to help the CEPAC?
I think my first comment, and Brett, I think, is more steeped in the details around, was it Demopolis was the other meta-analysis?
Right.
That is a more contemporary meta-analysis that would have included relapsed and refractory patients. Notably, Felix 2013 did not include one of the classes that define triple class refractory, I believe, because that would not have been available on the market yet. But the fact that Demopolis gives very similar results on an overall basis was a source of comfort for us.
And that conference proceeding had about 8,000 multiple myeloma patients, somewhere in that range.
Okay. All right, folks, let's go ahead and vote on this one then, seeing no hands raised. I know we've spent some time on it earlier as well. So please go ahead and vote. A is yes, B is no. Given the currently available evidence, is it adequate to demonstrate the net health benefit of belantamab is superior to that provided by usual care? And Elise, please let me know if I should not be waiting for 15. But otherwise, I think
You
we
should have 15.
Okay, good. We do. Can we see the results, please? Okay. 5 yes and 10 no. All right, let's go on to the next question, please. Okay, slightly differently stated patient population, so let me read it. Patients with triple or quad refractory multiple myeloma who have tried at least 3 prior lines of treatment. And again, this is for both of these drugs, ide-cel and cilta-cel, it's consistent with the entry criteria in the key studies. So the first vote will be on ide-cel. Given the currently available evidence, is it adequate to demonstrate the net health benefit of ide-cel is superior to that of usual care? Say again, I know it's probably the exact same tables, but just briefly summarize the rationale of the ICER team as it gave it its evidence rating.
Yeah, so it's exactly the same tables 2, 3, and 4. And so the summary the main data points that led to our estimate of a B+. So high likelihood of some benefit and possible substantial benefit are the increases in both progression-free survival, overall survival, overall response rate, as well as the clear benefit statistically and mostly clinically significant health-related quality of life benefits. So I feel like all of those suggest that this is better than usual care.
Okay. So we're going to address questions about the modeling when we get to the value question, but does anybody have any questions about the clinical effectiveness data and their thinking behind how they're going to vote here? Going once. All right. Okay, let's go ahead and take the vote. All right, this is for ide-cel. Is the currently available evidence adequate to demonstrate net health benefit over usual care? A is yes, B is no. You can see the results, please. All right, unanimous 15 yes, 0 no. Thank you. Okay, guess what the next question is? The exact same patient population. Now we're asking about cilta-cel. So Say, over to you again.
Yeah, so I think the biggest difference between cilta-cel and ide-cel is that the data for cilta-cel is less mature, and so there is more uncertainty. I think some of the downsides is that there are more treatment-related deaths with cilta-cel. However, if you look at the although immature progression-free survival and OS data, it may be that cilta-cel may be more efficacious. So I think there's some evidence to suggest that, so for both of those things, we ended up giving it a similar rating as ide-cel, as high likelihood of some benefit, some likelihood of substantial benefit.
Okay. And I know our CEPAC is familiar with this, but a B+ in the ICER rating world is not the grade that you're ashamed to bring home to your parents in any way, shape, or form. It just means that we don't have enough certainty early on to say how much better it is over usual care or the comparator, whichever it is. All right, any questions on this one? Albert, please.
Yeah, just a quick question about, this has been, I think may have been covered before, apologies, but usual care from the Mammoth study, it's a mix, it looks like it's a mix of a lot of antibody therapies, but is there also stem cell transplantation? Is it literally half a dozen different therapeutic options in usual care?
Yes. So, Jen, and I'd love to hear from Dr. Rajkumar or Dr. Souza about additional details, but it was a large market basket of kind of potential treatments. So they included alkylator-based treatments, as well as some of the other antibodies that you mentioned, like elotuzumab. So there are a variety of, I think some patients were getting panobinostat. So there's a lot of other regimens that it was in that market basket.
Including transplant?
Is transplant's not an option?
I don't believe so, but Dr. D'Souza or Dr. Rajkumar, can you help us with this?
In my clinical care, I would certainly include transplant as an option. Even in patients who have had a former transplant, doing it a second time can sometimes be an option. So yes, these would all be included within the what constitutes as usual care.
But was it in the study?
Right, that's the key question.
Yeah, I don't think so. And I'm not familiar now to say offhand if there were any patients, but usually if we do consider transplant, it'll come in the first relapse, second relapse, or third relapse, not like, after people have become triple refractory or quad refractory. So the basket of treatments are comprised of treatments that, when we don't have any other option, we start mixing and matching drugs. Sometimes even drugs that patients have seen before, but maybe they had daratumumab in combination with lenalidomide, but now because we are like, scratching at the bottom of the barrel, we're like, maybe we'll do alkylator plus daratumumab to see maybe that'll give a new synergy or something. So it's all very much like trying to assemble a regimen that maybe potentially would work. And again, as long as the patients are in good performance status, given so many drugs, we can usually find something that you can put together that but they probably haven't seen the precise regimen, but they might have seen most of the drugs in that.
Albert, about 72% had received a prior transplant in the Mammoth study.
Yes.
It just helps me understand how, kind of get into the mind of the patient or the doctor facing the decision about what to choose, apart from the CAR T therapies.
Right. They would have had a transplant, but at the point you're making a decision, should I do Mammoth type treatment or belantamab or CAR T, that won't be an option at that time.
Yeah. So I think the only thing I can add is like there is a table where they show all the different regimens that the patients in the Mammoth study got. And the most common drug that was used was daratumumab at 28%. And then you have, elotuzumab at 15.8%. It's like 10 columns. Alkylators 37%. So it's but I don't see transplant as part of that table. So I can't say, I don't feel comfortable saying definitively that there's transplant wasn't, but it doesn't seem like it's not listed as one of the regimens that was used for this population.
All right. Thank you, Albert. Good question. Anybody else have a question before we vote on this one? Okay, let's go ahead and go back to the voting slide. All right, so again, the same patient population as before. This current question is about cilta-cel. Is the evidence adequate to demonstrate its net health benefit over usual care? A is yes, B is no. Great, let's see the results. Okay, 13 yes and 2 no. Just given the time, let's not debrief on that one. I'm going to assume that the two are more likely due to the relative uncertainty or immaturity still of the data, but it's still a kind of a super majority, if you will, say yes. So let's go to the next question, which is, is the evidence adequate to distinguish the two? You've heard a lot about both now, but say briefly again how your team thought through this and the evidence rating you gave to it.
Yeah, I think the primary thing that led to our statement of that the data was inconclusive was the number one, the preliminary nature of the cilta-cel data, but also the fact that the differences between the cilta-cel and ide-cel studies made it, I think, very difficult to figure out how the results are going to be, how the populations were different and how the results, how that would affect the results. So it feels, yeah, that's how we got to the I rating.
And just a tiny bit of ICER terminology here. The I is insufficient in this term, in this use. It's not inconclusive. It really does mean, and again, this is with currently available treatment, currently available evidence. So it does not mean that we have enough evidence to say that they are the same or different necessarily. It means that currently, according to that rating, insufficient. The judgment was that the evidence does not allow us to make a judgment at this time. It's insufficient to allow us to distinguish the two. Any questions about this one from the CEPAC? Okay, let's go ahead and go back to the voting question. So is the evidence adequate to distinguish the two? A is yes, B is no. Okay, answer is 15 no. All right. So noted. Let's move over to the, skip this one since the vote was no. We can go to the first voting. Okay. So just a word of orientation for the audience watching online. So there is a document that gives kind of background to these votes. They're basically the purpose, again, of these votes and some of background around the way that the voting structure is given. So I don't want to try to walk through that here because it would just take us too much time. But I do encourage people who would like to read for more background that the link for this document is being sent through the chat function. And I hope you will, if you haven't already, gone there, because it explains, again, the broader purpose that we have for bringing these kinds of issues into the voting structure and the rationale behind each of the items that we'll vote on. So the CEPAC knows more of this, and I'll just read the question out loud and then we'll invite some discussion around it. So when making judgments of overall long-term value for money, what is the relative priority that should be given to any effective treatment for triple-class refractory multiple myeloma on the basis of the following contextual considerations? So here again, we're talking about any effective treatment, not any one of the three that we've been talking about. So looking at the condition itself, one contextual issue is the acuity of the need for treatment based on the severity, the short-term fatality, if you will, of the condition being treated. And the voting ranges from very low priority to average priority to high priority to very high priority. So again, this is not, again, about the treatments per se, it's about the condition and a relative priority that might be given based on its severity, its short-term fatality. So could I ask one of the clinical experts again, for these patients, what is their expected life expectancy at the point at which they're triple refractory? Basically, without CAR-Ts kind of being on the table, if you will, and whether some of those patients might have a long-term durable response. What is the general view of the short-term kind of life expectancy for patients at this stage? Vincent or Anita, do you have a?
I think usually we say about 4 to 6 months. I know that in the Mammoth study, the numbers came slightly higher. But that's probably what we would say. Like when somebody is triple class refractory, we usually have other options, but we are saying we'll remove these options away and then look at what it is. I think the median will be 4 to 6 months. There'll be some patients who are pretty sensitive to alkylators who can go on for a long time, but.
Okay. And Dr. D'Souza, does that match your experience?
Yeah, I think that one of the things I think of and also counsel patients is when we look at the data that's published, that's behind by a few years. So this number keeps evolving, and I would say that, yeah, like 6 months seems like a good average. Maybe I might keep it a little bit higher, but certainly under a year seems fair.
Okay. Thank you. That's very helpful just to frame again the thinking of the CEPAC behind the voting question. Why don't we go back to the voting question? I'm sorry, I should have, before I do that, does anybody have a question or a comment before we take a vote on that? Okay, let's go back. So based on the acuity of the need for treatment, based on the severity of the condition, and by here we mean patients at this stage of multiple myeloma, should the priority be accorded any effective treatment? Very low, low, average, high, or very high? Please go ahead and vote. Okay. All right, we can see a spike at 9 for high priority, 4 very high priority, and 2 average. All right, thank you. Let's go to the next one. Okay, so here again, the same preamble about making judgments of overall long-term value for money. What's the relative priority for any effective treatment? Still for triple class refractory patients with multiple myeloma. And here the contextual consideration is the magnitude of the lifetime impact of the condition being treated. The CEPAC knows that here we're actually talking not just about the 6 months-ish left for many patients without treatment, it's the lifetime impact of multiple myeloma, and whether that magnitude of its effect over the life course represents, in the sense, a very low priority for any effective treatment for patients, low priority, average priority, high priority, or very high priority. And we've already heard some kind of comments from patients around, the years that they've had this. We still have, Tom Belfort and David Mitchell with us. Either one of you gentlemen, I think you've already kind of shared some of this with us, but not just your own experience, but from what you know of fellow travelers with multiple myeloma. What do you think is the general view of the lifetime impact of this for people? David, can I start with you?
Well, I think I can't speak for any other patients. It was life-changing for me because I have been in continuous treatment since diagnosis, and I have suffered side effects as a result of those treatments, including a blood clot, including 2 GI bleeds, including, of course, at diagnosis, I had to have a balloon kyphoplasty. I used to be 6 inches taller. That's a joke.
I know that.
And so the day-to-day side effects that come with it have been discussed at length. The fatigue, the problem with dexamethasone, which all patients can tell you about. Now I'm on DARA and pomalidomide and bortezomib, and they all, especially when you mix in the dexamethasone, take a toll. There's a cycle that I live through every couple of weeks from those drugs. I know what it is now, and I can manage it. So there's a big impact on your life if you're a patient. On the other hand, I'm blessed because, if I would have been diagnosed 5 years before, there wouldn't have been this choice of treatments to be used, or to be used in combination the same way that Dr. Rajkumar was talking about, cooking up a new one, that might be unique to a patient. But when you come up to the point we're looking at now, where you become triple or quad refractory, and there are only so many things left, then the lifetime impact is there, but it's been okay. But then you're confronting something that looks like death, and this is a very difficult conversation to listen to, frankly, because of that. So I think I've answered. The lifetime impact is a lot, and yet the treatments are such that mostly you can manage it as long as you can weather both the adverse events and the side effects. And then, I dread the day when I come face to face with having a doctor like Vincent have to say, we're going to try a new mix, hasn't been used before. See how you do. That will not be a good day.
All right, thank you. Tom, anything you'd like to add?
Well, I think I would concur with much of what David has said. This is my 5th protocol. It's the first protocol that has CAR-T that has given me MRD negative. I've never experienced that before. The fact that I no longer have to go to the hospital 3 times a month for infusion has been incredibly liberating. I would say CAR-T has been a lifeline for me, and I'm now 14 months out and still MRD negative. It's been great, and the side effects have been truly minimal. So even though I am fatigued, I remind myself, number one, that in spite of being fatigued, there are various scales of being fatigued. I lead a perfectly normal life. whatever tiredness I experience does not impinge on my activities, I have nothing but praise to say about the CAR T.
All right, thank you very much. Alan, I see your hand up.
Yeah, the clarification question for the context of this. Are we supposed to think about the lifetime impact sort of post-treatment as is being described very sincerely by Tom and David, or is this more of a question about the lifetime impact throughout the entirety of life, and therefore, because of onset of multiple myeloma later stage, there's a lot of life lived without multiple myeloma. So if you're prioritizing overall impact across the entire lifespan, that's a different question than post-treatment impact on lifespan. So can you help differentiate between those two sort of temporal considerations?
Well, I'm not, well, the easier answer is probably about the fact that because we have two questions, one is kind of for the short-term severity, and this one is really meant to capture the kind of longer, the breadth of the impact on people's lives, that I would think about it in the broadest sense in terms of the beginning of when it starts to affect people's lives. And that usually is when they start, when they get diagnosed and get started with treatment. But it's not meant to imply, in this case, just the point at which they're triple refractory.
Okay, thank you.
Sure. Vincent.
So just want to comment, I'm not sure that it's relevant to this question, but it struck me as David and Tom were speaking, is that unlike many other cancers, the type of chemo treatments that we use for myeloma actually make patients live a fairly normal life. Even though it sounds like there are 3 drug refractory, 5 drug refractory, most patients look like David and Tom. They're fine, they're sitting, talking to me, and it's not easy to tell them that, well, we ran out of options. It's easy to imagine cancer patients who have failed 4 or 5 treatments to be very, very ill and on their deathbed, and they're not moving, and here I am trying to give another treatment. That is not common till like very, very, very late in myeloma. Most of the time when we are talking triple class or even penta refractory, patients do look like they have good quality of life. They haven't lost their hair, they're living a nice life. They're basically once a week they might get treatment, but most of the other treatments are daily by mouth. So that's what makes it hard, because a treatment that can help them for a year could be enough for me to give them 1 good year quality of life, and then get another one by that time that'll give them another 1 year, and so on.
Got it. Got it. Actually, that's a very good point. I think that may even be more relevant when we come to the next set of questions on potential other benefits, because what that extra health can do for you, as you said, may depend a bit on what functional status you have coming into the treatment. Okay, that's great. Reem, sorry. Oh, no, Reem, I see you. Yes, please.
I have a quick question. I don't know if it relates to this specifically, Steve, but some of these medications, so it's 3 to 6% mortality rate. And is there a way to predict who's not going to do well or who are going to have really poor reaction, or is it just really luck?
Let's hold that question, because it's more around the clinical selection of patients in use that I think we'll come back to when we talk about it at the roundtable. So it's a good question, but I think at this stage, let's go back. David, you didn't have another point, did you?
I do real quick if I
Oh,
can.
you do, go ahead, sorry.
I think it's also important to remember, while all of us want to focus on overall survival in myeloma, because the drugs are used sequentially and then they're combined, progression-free survival to me is an important measure. And it's even more important in the context of I might get some time on that one drug, and then they might be able to use it in combination and do things that the clinical trials didn't even show. And so progression-free survival for me as a patient is a critical measure, because we don't know how the doctors who are skilled in applying these drugs will use them.
Understood. Good point. Okay, let's go back to this second of the contextual issues, this magnitude of the lifetime impact, and let you vote again. I'm thinking about it broadly. Does this represent a very low priority, average priority, high priority, or very high priority? All right, the results are 8 average and 7 high. Okay, thank you. Let's move on now. The next set of questions are framed differently because they're each going to be about one of the treatments, or at least in this case, one, and the others it's going to ask you about both CAR-Ts. So again, these are asking now more specifically about the relative effects of this treatment versus usual care. So you actually now have to think not just about the condition, but how much better you think this treatment is versus usual care, and whether that has, if you will, broader effects outside health. And we've worded it this way. Here, the question is about whether that relative effect of belantamab versus usual care is, how does it affect patients' ability to achieve their major life goals related to education, work, or family life? Does that relative benefit, if any, that it offers suggest a major negative effect, a minor negative effect, no difference, a minor positive effect, or a major positive effect? So here again, it would be nice to hear from the patients on almost what you were just talking about to a certain extent, but basically, if there is an added progression-free survival or overall survival, we've tried to capture its health benefits. If you think broadly, how do you think that would affect people's ability to achieve their major life goals, whether it's education, work, or family life? Can we go back to see the full group? Thanks. So again, you've kind of touched on this, but it's just a point at which I'd certainly invite further comment from the patients, either one of you guys. David, if you don't, that's fine. But effects on ability to come back to work, longer term aspects of career planning, that kind of thing.
It's a very big deal, particularly the idea of being able to go through CAR-T treatment one time and not have to go on maintenance of anything, for example, because I literally have been taking drugs for 10 years constantly, a bunch of them, and then drugs to manage the drugs. So when I look at these CAR-T treatments and think, wow, if there really is a durable response, like 12 months is good, but what if we could get 2 years, 3 years, and without having to take other drugs and to live an otherwise normal life? That's huge. It's not a cure because it won't last forever, but doggone, for those 3 years, it comes about as close, or whatever number it is when we know how long it lasts. For those years, it's as close as you can get. So I would say it's an enormously important and valuable factor to be considered.
All right, thanks. I'll just note for the CEPAC that we'll be voting on this same issue for the CAR-T treatments as the next in the next set of votes. This one's going to be about belantamab first. Tom, anything you'd like to add to what David said?
No, I think, again, being 76 and being retired, my work life has not been affected, although I was a freelance person, and while I was on Regimen, I was able to spend 1.5 years in LA and continue working. And so at that point, the Regimen gave me, again, I wasn't tethered to the hospital. I wasn't tethered to infusions. So I think the more treatment options we have as patients, the more positive we feel about a possibly good outcome. And again, it's not a question of cure, it's a question of how long. Thank you.
Great. Okay, any questions or comments from the CEPAC? All right, let's go back to the vote. All right, so in this case, again, thinking about belantamab versus usual care and your judgment about that, how much does that have in terms of further effect on patients' ability to achieve major life goals related to education, work, or family life, from major negative to major positive. Go ahead and vote. We are almost there already. All right, we've got 11 no difference, 1 minor negative, and 3 minor positive. All right, thank you. Let's go to the next one. We're probably going to be able to just take this vote, although I will, again, without leaving the voting screen even, we might just, if David or Tom want to jump in, same exact question about the same drug and its difference versus usual care. Now we want to say, is there potentially a kind of a major negative to major positive effect on caregivers and their quality of life or their ability to achieve major life goals related to education, work, or family life in this situation? So it is a condition of adults, but still caregivers, family members are an important part of everybody's life. David or Tom, please feel free if you'd like to say something about the outside effects of treatment that benefit the patient that also could benefit the family.
In the case of Blenrep, right now I can drive myself to treatment every 2 weeks. I can go to the doctor for related matters. I can take care of myself. If I lose my vision and can't drive, that's going to have a huge impact on my wife, who would be the primary caregiver. And so I think that this needs to be taken into account specifically in relationship to Blenrep and the keratopathy and the other vision problems. It's a factor.
Okay.
I think that my only comment is about DEX. And I think that for 6 years of my life, roughly, I had a combination of different protocols, which included DEX. And DEX, I mean, again, always happy to stay alive, but DEX was really had a negative impact on me and on my relationship. So just the sheer absence of it is a joy.
Okay, good to know. Thank you. All right, let's go ahead and vote on this one then. Well, it's up. Oops, I think we need to start over. Sorry about that. If everybody can, wait, should they vote now? I think they can vote now. Please go ahead and vote. Okay. All right, so we've got 8 no difference, 6 minor negative, and 1 minor positive. All right. The next question is, do the relative effects of belantamab versus usual care, do they have an impact, an effect on society's goal of reducing health inequities? Obviously, this frequently occurs when we're looking at conditions that have preponderant effects within communities that have suffered health inequities in the past. But if anybody has a question or a thought on this, Stuart, please go ahead. Oops, you're still muted.
This will apply to obviously both categories of drugs, since we're dealing uniquely, at least in my experience with ICER, a condition that is twice as common in African Americans than white patients. And then I don't have the data for each of the studies, but I know for one, it was 4 times as many white patients in the trial as there were African Americans. And so it's hard to estimate the effects negatively on inequities, but the more complicated the therapy is, the more likely that inequity will persist unless there's interventions to mitigate that. So I just wanted to say those things as emphasis for the 2 discussions.
Stuart, thank you. You've teed up one of the first things we'll talk about in the policy roundtable as well, which is how to bring new innovations like this into the system with a view towards reducing inequities. We haven't talked that much since the introduction about the fact that this does have a higher incidence or prevalence in Black, kind of the Black population in the United States. Clinical experts or patients, do you guys feel like this is again, a good opportunity, an important opportunity that you think the relative effectiveness of belantamab or the other treatments could have an effect on social health inequities?
Wow, you just went to a big uber question there, Mr. Pearson, Dr. Pearson.
Steve, to you, David.
You know, what we see in multiple myeloma with double the likelihood of an African American contracting it, double the likelihood of death as a result, is what we see across a lot of different illnesses and diseases in our healthcare system. And it's unfortunate that African Americans tend to be underrepresented in the trials, which just compounds the issue. I would say that given that it disproportionately affects African Americans, any improvements in treatments that reach African Americans is good. That's all I can say.
All right, and we'll talk about that reach later. Vincent, looks like you wanted to come in, please.
Well, you know, the problem is that the more expensive the treatment, the more detrimental the effect on existing inequalities. Unfortunately, the disparities will only widen the more expensive the treatments. I'm afraid that CAR-T and belantamab are not going to reach many African American patients. And we have shown that if they do have access to therapy, then the lifespan is identical to whites or even sometimes better than whites. But the reality is they don't. And the more expensive the treatment, the more wider the disparity will be.
Okay. I see some nodding heads. And again, we'll come back to this issue and talk about potential solutions or at least attempts to address this issue, this problem. Thank you for,
and
thank you for
if I
raising
may, we have to
Anita.
also think of disparities beyond race. Many of these CAR-T, more complex ADC type treatments are currently only provided in larger tertiary centers. So also think about patients living in rural areas or farther away from these high volume tertiary centers. And I think that can also introduce a disparity.
Okay, thank you. Alan.
Well, the only thing I was going to add, at least in fairness, on this question specific to however you say it, belantamab, is, and correct me if I'm thinking is wrong, but because it asks us to think about this question in the context of comparison to usual care.
Right.
I think we've already established usual care is expensive across the board here. So I don't necessarily know if this additional therapy is any different, you know, the impact on these issues will be any different. It seems like it's just the same thing repeated. But I'm wondering if I'm thinking about it the wrong way. But that was sort of my way of thinking about it, is compared to other therapies, even if this is expensive, they're all expensive. So I was sort of thinking about the answer relative to the cost of other treatments.
No, you're right. I mean, that's part of it. I mean, this is a multidimensional issue. I mean, question, as you've already heard, is belantamab better than usual care to start with? Is it easier to get to rural communities or
relative to usual care?
Yeah, lower cost, all relative to usual care. I mean, we could all hypothetically imagine a perfect treatment that would be easy to use and cheaper and better. And again, certain situations, this will be an obvious yes or an obvious no. In a way, this is going to be asking you guys to think about a variety of different factors. But let's go ahead and go back. I think that was a good discussion. We want to capture this, and we'll turn to the same questions for CAR-T. So here, the relative effects of belantamab versus usual care. What is the relative effect, if you will, on society's goal of reducing health inequities? A major negative effect up to a major positive effect. All things being considered. All right. Okay, so it starts at an 8 with no difference, and the others are headed in the minor or major negative effect regard. Okay, let's move forward then. I believe we're now shifting. Okay, I don't think we actually have to go back and talk what you guys did a great job already, all of you, is to kind of bring up the issues in relation to both belantamab and the CAR Ts. Now you do, the CEPAC, you do have to think about the relative effectiveness that you would view of these treatments. And obviously they have some other distinctive facets as well, but we're going to ask you about the same effects on things like patients' ability to achieve their major life goals related to education, work, or family life. I don't think we need to go back into what we heard from patients because it was almost directly related to RT as much as belantamab that we were talking about. Does anybody have a question that they would like to ask of the patients or clinical experts or anything else? Okay, Alan?
Yeah, I noticed in the background, the evidence report on, I don't even remember the page, but there was 2 patient stories from the CAR T area that would be relevant to this question. One of whom, and I think it's consistent with what Tom was describing, sort of the freedom from, once you get through the treatment phase with the CAR T, the freedom from frequent visits and the traditional drug regimen and the follow-up visits. But there was also another patient that actually still had to be on maintenance therapy and did not have that same freedom. And I'm wondering if, and I also noticed in the economic model, it almost, and I was going to ask this back when we were discussing, we ran out of time, it almost seemed like the model actually did not really take a side on that issue, that it sort of assumed on slide 45, the sort of step 2 or the stage 2 of the assumptions behind the model. It kind of assumed all the follow-up, the maintenance therapy, follow-up visits, everything would be the same across all the different treatments that we're considering here. Maybe I'm correct in that assumption. I guess my question is, do we have any evidence to suggest, other than what we've heard anecdotally, that there is a consistent pattern of this freedom from the drug regimen and maintenance therapy, particularly the DEXT issue, because I think that's significant, but do we have any evidence to support that, that we can use to inform this answer to this question?
Let me do it. I'll try to do it briefly, and then either the clinical experts or the ICER team can jump in. But I know that there's a general assumption that if a treatment is effective in putting you into remission, that you do not have to have the ongoing other treatments. You might have to have some, check-ins with your doctor. That might not stop, obviously, but it's going to be a much lighter load than if you're on continuous maintenance therapy and you have to go in for the infusions or what have you. We will talk at the policy roundtable about what you noted, which is that apparently there is some experience with patients who have had a CAR T and basically been continued on maintenance therapy. And we'll want to hear from the clinical kind of experts, their views on that. But I don't think it's, we need to specifically nail that down here for this answer quite so much. But the short answer, because I think the short answer is the general assumption is that the CAR Ts or any treatment that puts you into a complete remission, or into a remission, you would gain the benefits of having fewer requirements to be hooked into the medical system. At least for, as David was saying, 12 months, 24 months, 3 years, any amount of time, certainly at that scale, seems like a big deal to patients. Anybody want to add or disagree with me on that?
No, you summarized it perfectly, actually. Did you get your hands on the model somehow? Yeah, we did, Alan, include just the bare minimum laboratory monitoring, per month as just an assumption, but the additional treatment costs were only if patients progressed. So that additional, the other therapies, there were more check-ins related to the intervention, et cetera. So Steve explained it perfectly.
Okay, let's go back to the vote. Becoming slightly mindful of time. Okay, so for both CAR Ts, and this is worded this way because the evidence is insufficient to distinguish them at this time. So we're going to ask about both of them at this point. What about their ability to help patients achieve their major life goals? Okay, the results. Okay, so we start here with an 8 for minor positive, a 6 of major positive. Okay, we'll go to the next question. Because of the time, I think I will look for a hand to be raised for a question, but otherwise, because I think we did good discussion of this again. Caregivers' quality of life and their ability to achieve their goals, whether it's education, work, or family life, the CAR T's effect on that, from major negative to major positive. Please go ahead and vote. Okay. All right, 13 minor and 2 major. The next one is different. Okay, here we threw this one in because this is kind of a potential other benefit that we have heard a lot about. It's the complexity of the regimen of CAR Ts is very different, right? It's once you get it, at least after that, it's less complex, assuming you don't have to get retreated. So the question here is the relative effects of the CAR Ts versus usual care. And what do you think about the impact on patients' ability to manage and sustain treatment given the complexity of the regimen? This isn't a perfectly worded question for the situation, but as you know, CEPAC, it's meant to capture treatments through which a reduced complexity can have an effect on patients' ability to, again, just be adherent to the treatment, to benefit from it, etc. So again, we know that outlines the contours of the difference between the CAR T treatment and its timing versus an ongoing maintenance therapy. We've already talked about that. Does anybody have a question before we take a vote on this? Yes, David.
Are we taking into account the possibility of the need for a follow-up treatment?
I think to a certain extent, I would leave that to people's discretion, but I think the general guidance is to follow the evidence. And if the evidence suggests that there is retreatment, I know we heard a different comment on that from the company representative saying that that was in the past and it feels like going forward that won't happen. And just when I said that, I realized, why don't we ask our clinical experts? Because this is going to come up in the policy roundtable anyway. Do you guys think that there will be patients who will not benefit from the idea of a one and done, at least until something happens, a treatment effect? Will there be a lot of patients who will be retreated? None? What do we think about this? Anita or Vincent, what do you think?
I think if I had to predict it, it might not be retreatment with a CAR, but retreatment with another BCMA-directed agent, so either a BiTE or the ADC. So this the cycling of I think this is something that's still evolving, and but there are data now suggesting that patients can still respond to retreatment with a BCMA-directed treatment.
Okay, Vincent, anything different?
Well, I mean, I'm just going back to historical precedent with transplant. When transplant came first, autologous transplant, it was like one transplant and then you have 2-3 years of complete freedom and do your thing. But eventually it moved to, well, some people can benefit with the second transplant, particularly if you've done really well on the first transplant. Let's say the first transplant worked for 3 years. Now you're saying, hey, why not try it again? And the same way, when the transplant first came, it was like we do it and then we don't need to do anything. You have freedom from treatment. That was even a metric that was measured. But eventually someone does a study that says that if you do lenalidomide after the transplant, you can have double the freedom from, the progression-free survival. And then now we are doing both lenalidomide and bortezomib as maintenance for patients who are high risk. So this builds on. So I think, as Dr. D'Souza said, if this treatment works, you're probably going to find people wanting to use either the same or a different anti-BCMA strategy for as long as that target is there still and amenable to therapy.
Okay, thanks. We'll talk more about some of the historical perspective as well in the policy roundtable. All right, let's go back to the voting question and ask you, again, this is hard because it is forecasting, but what do you think we should think in terms of overall value about the impact of the CAR Ts on patients' ability to manage and sustain their treatment given the complexity of the regimen? Will this have a major negative effect up to a major positive effect? Let me go ahead and vote. Okay, 12 minor positive and 2 major positive. Okay, thank you. That's great. Let's move forward. Oh, I'm sorry. There is this question too. Apologies. So we've talked about this when we were going over the vote with belantamab. Again, this one is asking about the CAR-Ts and their ability to, their effect, I should say, on society's goal of reducing health inequities. I'm pretty sure we can go ahead and vote on this because of the prior conversation. So let's go ahead and do so. All right. Okay. And I think that's a very similar result, if I'm not mistaken. Okay, thank you. And I do believe that we are now into the home stretch on the voting. We have 2 votes left on long-term value for money. One will be on belantamab and one will be on ide-cel. So you've just walked through the course of a day spent hearing about the clinical effectiveness, the incremental cost effectiveness, and we've also just talked about the benefits, disadvantages, other potential benefits, disadvantages, and contextual considerations. So now the vote is around long-term value for money at current pricing with belantamab versus usual care. And the choices are going to be low, intermediate, or high long-term value for money. And Brett, let me just ask you this time to briefly summarize and point to the tables around the results of the cost effectiveness modeling, which are a piece of this vote.
Yeah, thank you, Steve. And if you look at the evidence summary table 7, that's going to break out the intervention, non-intervention, and total costs, as well as the 4 outcomes that we've estimated from the model. Then you're going to look at the bottom row of table 8, which includes the incremental outcomes, cost per quality, cost per life year, cost per equal value of life year gained, and then the alternative metric of cost per additional PFS month gained. So if you have any questions, I'm happy to answer those.
Okay, so we started a base case at 98 or 93,000 per quality or equal value life gained, respectively. And we had already talked a fair amount about some of the aspects of the modeling. Would you like to highlight any particular area of uncertainty or a finding of a scenario with sensitivity analysis that you want the CEPAC to think about before they take this vote?
Yeah, I think there's 2 points. The first was the one that I made about table 10, which is in your evidence summary. And it shows the number of iterations that met the cost effectiveness threshold in 100,000 per quality. So remember, it sits the base case right at 98,000. However, when we repeat and we have uncertainty both around survival, around the prices, you remember how close they were to the market basket, both in terms of prices and survival, only 50% of those actually met the 100,000 per quality. And then the scenario analysis that we presented, where the PFS relationship, instead of being 1 to about 5, is 1 to 3. And to clarify an earlier point from GSK, the Demopoulos abstract only was relapsed remitting multiple myeloma. So the Felix paper actually combined the earlier lines and later lines. So we're seeing out of about 8,000 multiple myeloma patients that contemporaneously is still fairly consistent in the relapsing community. So just those 2 scenarios and sensitivities to point out.
The last piece of guidance or suggestion for what you are mulling on now is that I know some of you may be thinking, wait, I voted that the evidence wasn't adequate to say that it's better than usual care in the first place. What should I say about its value? My guidance is to think of that as a piece of the uncertainty that percolates through all of these votes to a certain extent. You had uncertainty, if you voted that way, you had uncertainty about the clinical effectiveness. You may have others of you may have questions about the uncertainty on the cost effectiveness or around some of the potential other benefits and contextual issues we've discussed. So it's easy to suggest that might start you out at a lower value consideration if you had significant concerns about the basic effectiveness data to start with. But it doesn't mean that you have to vote that way, or it doesn't mean that you shouldn't vote. Does anybody have any questions or want to kind of disclose their own way of thinking through this as a guide or a warning signal to others around how they're going to vote? Do people understand fully, they think, what Brett was pointing out in terms of the multiple iterations and why you can get a one-time finding? And if you bear, okay, I'm seeing a lot of nodding heads. Okay, Bijan?
Yes, Steve, my question is about this long term, like, how are we defining long term here? Because when you think about it, the patients that would be entering for these treatments, they could be probably most likely 65 plus, maybe around 70. So when we long term, I know that this is a lifespan model, so that kind of throws me off. I mean, when we say long term value for the for these therapies, what exactly do we have in mind, or should we have in mind?
I'll let Brett give the specifics, but the long term is just meant to imply that is the length of the model horizon, which is lifetime in this perspective. And yes, I mean, they're older on average when they start, but it's not a truncated, shorter term view of value. So that's the generic meaning of what we mean by long term. Brett, is there anything more to say? It's just a life table approach to these patients.
Exactly, and we just want to make sure that our time horizon reflects the benefit of the treatment. And so I think it's important that we extrapolate that over the lifetime, knowing full well there are assumptions involved in that. However, the belantamab evidence is, far further along than the CAR T therapies in this case. We have longer follow-up, more certainty around survival itself for the base case, but then as Steve mentioned, there is uncertainty just given that the survival is so close to the usual care. If that makes sense.
Thank you.
Any other questions or comments before we move to the vote? Okay, let's go back to it. All right, you've heard about this question before. Integrating these features that we've talked about today, please vote on whether the overall long-term value for money of belantamab is low, intermediate, or high. And we have all the results. Please go ahead. Okay, 8 low and 6 intermediate and 1 high. All right, let's move to the last voting question. So I think it's pretty clear that we chose not to vote, by the way, on cilta-cel because of the prematurity, if you will, of the evidence. That was the primary reason, including the fact that we don't have a price for it, et cetera. So the one question will be about ide-cel. And again, I'll just restate the obvious, which is this is asking you to integrate in your thinking the findings of the incremental cost effectiveness results along with the other features of the discussion today. Brett, one last check on what the base case or other key scenario analysis results were.
Yes, so table 5 explains again the broken out discounted base case costs as well as outcomes. Then table 8, first row, shows the incremental cost effectiveness ratio, cost per quality gained of about 320,000, cost per life year gain of about 250,000. Then kind of, as I explained, equal value of life year gained right in between at 280,000. Some scenario analyses you may want to consider are around that retreatment estimate. And in the base case, we assumed retreatment because why wouldn't we pay for a therapy that was administered, whether it be once or twice? But I think it is important to consider the potential where maybe payers wouldn't allow for a retreatment. I don't think it's fair to say one way or another, but we provide that for you and have your own interpretation in mind. So I don't know, Steve, if you wanted to add to anything on that.
What was the result of the scenario analysis without a second treatment?
Yeah, it was approximately 250,000.
Okay, just so they get some context. Okay, any questions about evidence underlying your thinking here? Alan, was this one of the issues that you wanted to come back to, and am I misremembering now? Because I know you had at least one question that didn't get addressed earlier. Was it related to this or not? Nope. Okay.
No, it wasn't. Thank you for asking.
Sure. Okay, let's go ahead and take a vote. All right, A is low, B is intermediate, and C is high value. All right, just waiting for one more value vote. Everybody just check to make sure that your vote went through. There it is. Oh, no. Somebody re-voted. Okay, there we go. Okay, 9 low and 5 intermediate. All right. Folks, thank you very much. That was actually one of the smoothest technical voting procedures we've had. You guys did a great job getting the votes in on time and with the discussion. And we are on time with our break. Let's come right back at 2 o'clock. CEPAC, please come back a minute or two beforehand so we can kick right off